Greetings all. We're going to do the rest of this month's gas case in this format, just a little PowerPoint screencast / video for some explanation. And the primary reason we're moving to this for this month is for our Academy students. This lecture will also be used as an introduction to blood gas interpretation for our Academy students. So welcome to our new Academy students. They're well into their online weeks, and their first face-to-face week is not too far away. So we're going to walk through the case that Star 7 brought to us. We're going to go through the one-pager for blood gas interpretation, the four-step interpretation that's part of that one-pager. We're going to review total CO2 and how the ISTAT handles that. We're going to review a wide anion gap metabolic acidosis. We're going to talk about lactate. We're going to talk about compensation and its winters in this particular case that we'll use, and indications for intubation as they relate to this particular case. So here is our one-pager. You guys all have this. This one-pager is derived from this article here. This is about 8 years old now, published in the New England Journal. It was a really good review article, and we're going to post this both in the monthly e-learning, and for you Academy students, it'll be in your Moodle as well. And it's worth a read just to see the background. As I said, it's 8 years old, but things haven't changed much in this space. We use the way we interpret blood gases at STARS is called the physiological approach. It's the most common approach to blood gas interpretation that's out there, but there are other approaches to blood gas interpretation, just so you know. And a few months ago, Mackenzie Wardle gave us a little pocket version of this one-pager. So thanks again to Mac. And if you don't have this, just reach out to Mac, drop him an email. He'll be happy to send this along that you could keep in maybe a little more easily accessible hard copy version. I personally just keep the one-pager available to me in my Dropbox, which I have available to me on my phone. So review or reminder that it was Star 7. We had Sarah, Paul, and Danny, and they went out to the 65-year-old female that appeared to be in liver failure. And she presented to the peripheral emerge that day after developing altered LOC on the background of 2 weeks of abdominal pain, nausea, vomiting, possible hematemesis, possible melena, and worsening jaundice. So just as a quick reminder, with altered LOC, I kind of like this mnemonic, dim top. It's descriptive. They're altered, so they're dim up top. And it's not completely comprehensive, but the D stands for drugs, the I stands for infections, both central nervous system infections as well as systemic infections. The M stands for metabolic, big broad differential diagnosis there. T stands for trauma as well as non-traumatic brain lesions. O stands for oxygen deficits, i.e. hypoxia, and there I also include hypercarbia. And finally, P stands for postictal and psychological. So yeah, I just kind of keep that, again, not completely comprehensive, but decent starting point as an approach to someone with altered LOC. Here was our gas. And so let's interpret this gas. So there it is there again. We've got the one-pager in top right. So four-step interpretation, the first step is pH. So is this gas acidemic? Is it alkalemic? I'm using the emic intentionally, of course. Emia refers to blood. Hypokalemia means low potassium in blood. Hypoxemia means low oxygen in blood. So this patient is clearly acidemic on that blood gas. So that's the first step. The purpose of the second step is determine the primary disorder. And the reason we do that is if you look at the interpretation tables on the top right, the first column is primary disorder. So this just helps us with our fourth step, which is determining compensation and whether it's appropriate or not. It's not many patients have more than one acid-base disturbance, and we're not saying any one is more important than the other. It's just that this step 2, is done so that we can then do step 4. So if we look at and we only look at two values, we look at the CO2 and the bicarb. Which one of those values, or do they both, explain the deviation in the pH? Well, the pH is low. So does a low PCO2 explain that deviation in the pH? No, it doesn't. A low PCO2 is a respiratory alkalosis. That would not explain an acidemic pH. If we look at the bicarb, does a low bicarb explain that change in pH? Yes, it does. A low bicarb is a metabolic acidosis, and that would explain an acidemic pH. So the primary disorder in this case is a metabolic acidosis. Okay, let's go to step 3. You can see that step 3 says if metabolic acidosis, calculate an anion gap, or look at the measured anion gap if you have a Chem 8 available to you. So let's look at the Chem 8 in this patient. Here it is. So the traditional way we calculate an anion gap is the sodium minus the chloride and the bicarb summed together. So if we look at the chloride, 97, and we look at the bicarb, you'll notice the Chem 8 does not display a bicarb. We're going to talk about that in a second. The way it estimates bicarb is takes away 1 from the total CO2. So 97 plus 8 is 105, and the sodium is 131. That gives us an anion gap of 26. Know that the Chem 8, when it displays its anion gap, you'll see down in the bottom right, it displays an anion gap of 30. That's because it includes potassium in its calculation. So we've got to add 3.7 to 131, so that rounds to 4. So 131 plus 4 is 135 minus 105, which is the chloride and the bicarb summed together, is 30. So the answer, depending on whether you include potassium or not, the anion gap is 26 or 30. Either way, it's high. The reason this is a little bit important is because you need to change your normal ranges. So if a normal anion gap is somewhere in the range of 8 to 12, maybe 8 to 16 in all of us listening to this call, when we don't include potassium in the calculation, our normal anion gap goes up a bit if we include potassium. If you think a normal potassium is 4, that means your range is going to change to like 12 to 20 for everyone sitting on this listening to this presentation right now. And so it becomes a little bit of an issue there when we're trying to figure out if the patient actually has a high anion gap or not. So do know that when it says 30 on the Chem 8, that's going to be a little higher than what you would traditionally think it is based on not using potassium in the calculation. In this case, with the potassium being 4, that 30 translates to an anion gap of 26 in the traditional way we calculate it. Either way, in this case, it's high. So let's talk about that. These are the total CO2. So these are just screenshots from the Abbott point of care manual. Of course, ISATs are made by Abbott. And you can see how the total CO2 is calculated. So the total CO2 is always going to be a little bit higher than the bicarb. Now, if you think of a normal partial pressure of CO2 of around 40, 0.03 times 40 is 1.2. So that's where they derive the number 1. So you can see in the third line there, the anion gap on the Chem 8 is calculated as the sodium plus the potassium, which we just talked about, minus the chloride, plus the bicarb, and the bicarb is estimated as that calculation right there. Just take 1 away from the total CO2. And you'll remember that from event course a few years ago, that the total CO2 is a reflection of bicarb and is always just a little bit more than the bicarb. So if you got a Chem 8 in this patient before you got a CG4, you would already know the patient has a metabolic acidosis. You don't know what the compensation is like, you don't know what the pH is like, but you know their bicarb is around 8, and that's low, and that's a metabolic acidosis. What about a differential diagnosis for a high anion gap metabolic acidosis? I like the term CALT. It helps me separate it into endogenous and exogenous causes. So endogenous is the first 3 letters, KUL, so ketoacidosis, so things like diabetic ketoacidosis, starvation ketoacidosis, alcoholic ketoacidosis, anything that produces ketoacids can give you a high anion gap metabolic acidosis. Uremia, which is another word for renal failure, will do this as well. They don't secrete the acids as well. Those kidneys that aren't working, they don't generate, those dysfunctional kidneys don't generate bicarb as well. So that can give you a high anion gap metabolic acidosis. And finally, L for lactic acidosis. And we're going to go through an approach to an elevated lactate here shortly. The T I use as so-called toxins. And that's where I use cat mud piles or mud piles cat to help me remember all of the various toxins that can cause a high anion gap metabolic acidosis. And those toxins are included in this cat mud piles mnemonic. One note you'll see, if you remember from the case, this patient was on iron. An iron overdose can certainly give you a high anion gap metabolic acidosis. So we would keep that on our differential diagnosis for the metabolic acidosis in this patient. Let's talk about lactate for a sec. If you look at this patient's lactate, it is really high. The ISAT doesn't measure above 20, so it just tells you it's more than 20. So what is lactate? It's the conjugate base of lactic acid. We all produce it. We're all in kind of a steady state. So it's constantly produced from pyruvate. When you do a gas, you never see a lactate of 0, even in healthy patients. So the lactate level that you see on a gas results from the sort of sum of lactate production and lactate utilization. When the rate of lactate production exceeds the rate of lactate removal, you're going to start to see elevations in your lactate. Lactate itself is not like a toxin. It's more a marker of badness. Okay, so let's look at the causes of high lactate. So the traditional one that I think we all remember is this type A, which is a tissue oxygen deficit. So these things like shock states or hypoxia at a tissue level, or in extreme case, cardiopulmonary arrest. All of these things result in a deficit of oxygen at a tissue level. The body still needs energy, so energy is produced by alternative means, i.e. anaerobic metabolism, and there is higher lactate production when we have anaerobic metabolism. So we can see an elevation in lactate in those situations. And again, that's a type A elevation of lactate or a type A lactic acidosis. Type B is when there isn't necessarily a deficit, like a decreased availability of oxygen, but there's an impairment of O2 utilization. Things like sepsis can cause mitochondrial dysfunction and can result in impaired ability for the cells to uptake and utilize oxygen. Liver failure, it's on this list primarily because liver is the main organ that excretes lactate and gets rid of it. And so you'll remember in this patient, she presented with like fulminant hepatic failure. And so whatever lactate she was producing, she had a marked impairment in her ability to get rid of that lactate. And so liver failure is part of the type B lactic acidosis, and many toxins can do this as well. A third category is catecholamines. So beta-2 receptors, you'll recall that catecholamines interact with beta-2 receptors. Primarily it's epinephrine, but also norepinephrine. We can see this kind of similar issue conceptually when we give a whole bunch of salbutamol to patients. We often see their lactate go up. So when patients are stressed and they have functioning adrenal glands, they'll produce catecholamines in response to that stress state. And that in and of itself, when those catecholamines interact with the beta-2 receptors, can cause glycolysis and will result in elevation in lactate. And we can see this with exogenous catecholamines as well. And recall that this patient was on a norepinephrine infusion. So that's an approach to a high lactate. In this patient in particular, what are all the reasons? What do we have? We have the patient in liver failure. So whatever lactate is produced, they're going to have a marked impairment to metabolize that lactate and get rid of that lactate. The patient was in shock, had a low blood pressure, so that can cause a type A lactic acidosis. The patient was on norepinephrine, so that comes to our beta-2 receptor stimulation. And And there were actually sepsis was on the differential, and so that can result in some mitochondrial dysfunction, as can iron actually. Iron causes a lactic acidosis, often through shock states, but the iron itself can disrupt the function of the mitochondrium and can result in a bit of a type B elevation in lactate as well. So lots of reasons in this patient for a high lactate, which we definitely see on this gas. Let's go back to the 4 steps and talk about compensation. So it's winters, right? So it's a metabolic acidosis. So that takes us up to our top row here. And so that's our primary disorder. So that's marked by a decreased pH, which of course we see, and a decreased bicarb, which we see. The compensation that should occur is a lowering of the PaCO2. And how much it should drop is dictated by winters. And this, of course, is how much it should drop in a spontaneously breathing patient, which we have in this case. This patient is not intubated, is breathing on her own. So let's just go through the math for winters. I've got it laid out on the left there, but you can see it's 1.5 times the bicarb is the first step. The bicarb from the CG4 is 5.6. So 1.5 times 5.6 is 8.4. And then we're adding 8 to that, so we get 16.4. And then there's a range around that. So the final is 14.4 to 18.4. That's what the expected arterial CO2 value should be in this patient. Okay, so is the patient compensating appropriately? Winters tells us that the expected PaCO2 is 14.4 to 18.4. This is a venous sample. We know that CO2 is the value between venous and arterial samples that can vary the most. And so the other ones tend to be much closer. So this is a venous CO2. So what is the arterial CO2? Well, of course, we don't know exactly, but recall bracketing. Recall the order. The venous CO2 value is going to be the highest. The arterial CO2 value is going to be somewhat lower than the venous value. And the end tidal CO2 is going to be the lowest of the 3 values. Okay, so put another way, and this is where that term bracketing comes from. We have the venous that defines one bracket, the end tidal that defines the lower end of the bracket, and then the arterial value is somewhere in between. Now, it's not in the middle. It might be in a particular patient, but it could easily be closer to the venous. It could easily be closer to the end tidal. We just know it's between, somewhere between those 2 values. And where it falls, it'll depend on patient physiology, primarily things like dead space and also systemic perfusion, i.e. shock. Remember that Winters tells us what the arterial CO2 should be in a spontaneously breathing patient. You guys have all seen patients with metabolic acidosis. They tend to breathe deeply and they tend to breathe quickly. They are undergoing, though, negative pressure ventilation. Every time they inhale, they are creating negative pressure in their chest, which promotes venous return to the right side of the heart, which promotes Q. Q means pulmonary perfusion. You have to have pulmonary perfusion to ventilate CO2. So when they're breathing spontaneously, they're doing just that. They're drawing all this blood back to the right side of the heart, so hopefully their Q is optimized, and therefore they're delivering a lot of CO2 to the alveoli where it can be ventilated out. Winters is not a formula that tells you what your CO2 should be when you're undergoing positive pressure ventilation. And the reason for that is positive pressure ventilation. I think the main reason for that is positive pressure ventilation can impair Q. And if we try to gain a minute ventilation on the ventilator that matches the minute ventilation that patient is currently undergoing with their massive tidal volumes and their fast rate, we are going to introduce a lot of positive pressure in the chest. and that is going to impair Q. And we can have a minute ventilation of whatever we want. We can have a rate of 60. If we don't have any Q, any CO2 being delivered to the alveoli through pulmonary perfusion, that minute ventilation is not going to translate into ventilating out the CO2. And the CO2 will not get ventilated out. And yes, we'll have a very low end tidal, but this will not correspond with a drop in arterial. And we'll have a wide discrepancy between the end tidal and the arterial value of CO2. So what did this crew do? This crew determined, I'll just go back to this slide for a second, this crew determined that, hey, I know the arterial should be between 14.4 and 18.4, the venous is 20.7, knowing that even in normal people, the normal gradient is somewhere between 2 and 5 from venous down to arterial. I'm confident that that arterial value has a high chance of being somewhere in that range, and they made the decision that this patient was compensating appropriately at that point in time for the metabolic acidosis. So, do they have an indication for intubation? Well, for that, this is screenshot directly from our airway CCMCP, but here are our indications for intubation. So this patient has a patent airway, and all we're talking about there is a patent tract from the mouth or the nose to the middle of the trachea. The patient has that. Airway protection. So this is talking about the patient's ability to protect their airway against aspiration of anything other than air. So it's usually things like blood or emesis or secretions. This patient seemed to have a level of consciousness that was sufficient that allowed her to maintain her airway protective reflexes. So of course what happens when the airway is presented with any of those stimuli is the glottis closes. And this patient seemed to have those airway reflexes intact. Her GCS was about 12. And so the decision was made that that patient was protecting their airway against aspiration at that moment in time. Respiratory failure. This refers to hypoxemic respiratory failure or hypercarbic respiratory failure or both. The patient is not hypoxemic, so they do not have hypoxemic respiratory failure. And of course, this is on a continuum. Like lots of people are hypoxemic on room air, but respond quite well to, some O2 flow and get their SATs into a normal level. With respect to the hypercarbic respiratory failure, well, that's what we just did. That's the Winters compensation discussion that we just had. And the decision was made that this patient was compensating totally appropriately for their metabolic acidosis. The final indication, so we don't have an indication at this moment in time to intubate this patient based on our 3 primary indications. The fourth one is if you predict a deterioration in one of those 3 primary indications, and you predict that deterioration may happen in the near-ish future, such that you'd rather deal with the airway, now on the ground in an emergency department at a sending site versus in a helicopter. And of course, there's a lot of judgment that goes into that decision, but that would be the 4th indication for intubation. So this crew, I think quite appropriately, decided to not intubate this patient and brought the patient home to tertiary care. So I don't have access to an electronic health record in Manitoba. I think the chances of this patient having a good outcome, given their metabolic state at this moment and their absolutely completely failing liver, is pretty low. But I don't know what happened ultimately in this case. But I would hazard a guess that this patient did not survive this insult. All right, so we walked through the case. Thanks again to Star 7, specifically Sarah, Paul, and Danny for bringing this forward. We reviewed the 1-pager, the 4-step interpretation to our gas. We touched on total CO2 and its relationship to bicarb. We discussed the differential diagnosis for a wide anion gap metabolic acidosis. We talked about lactate, type A, type B, catecholamines. Talked about compensation. In this particular case, it was Winters formula, and then indications for intubation as it related to this case. So that is March blood gas /case. I hope it was useful. Again, big welcome to our Academy students. And I think we're likely going to do something similar to this for April again. So thanks all and happy spring.